Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center of Miami. Welcome to our Monday afternoon Instagram chat. Today's topic is implantation failure, or what to do when my embryos don't stick. And just to review, when we're talking about embryos, of course, we're talking about in vitro fertilization, which has a few basic steps to it. The first part is to stimulate the ovary, which normally in a human will produce a single egg, to produce hopefully 10 or 20 eggs. The second part of it is to retrieve those eggs, and then once the eggs are identified, inject those eggs with sperm and create embryos. The embryos are then left to develop for the next 5 to 6 days, at which time an embryo can be transferred at what's called the Blastocyst stage of development. An embryo at this point has 50 to 70 cells. Under the microscope, it looks like a little soccer ball. It's a three-dimensional rounded structure, and it has differentiation between what's called the inner cell mass and the placental cells. Most of our patients elect to biopsy these embryos and then cryopreserve them, and then we can transfer them. So embryos can be transferred back into the uterus, either on a fresh or a frozen cycle. If embryo biopsy is not performed, then most commonly 1 or 2 embryos are transferred on a fresh cycle. And if embryos are cryopreserved, more commonly they're transferred on a frozen cycle. And with transferring embryos, the number of embryos that are transferred are based on whether the embryos have been biopsied or not. If they have been biopsied for pre-implantation genetic testing for aneuploidy, we really recommend 1 embryo, and occasionally you can twist our arm and put 2 in, but 1 is really the best recommendation. If we're putting embryos back in a non-biopsied state where we don't know if it has the correct number of chromosomes or not, then we can be a little more aggressive, and in that case it would be age dependent. In young patients, we still recommend 1 embryo. In women over 35, you can consider 2, and in women over 40, even at a blastocyst stage, we would consider even transferring 3 embryos if they weren't biopsied, because of the high incidence of what's called aneuploidy or abnormal embryos. So an embryo is transferred either fresh on a frozen cycle. We wait to see the outcome, and depending on whether these embryos are biopsied or not and how old the patient is, we would have a general expectation of what kind of success we would have on a single cycle of embryo transfer. If the embryo is biopsied and we put back 1 normal embryo genetically, we would expect success rates of implantation to be 50 to 60%, with about a 10% miscarriage rate. If we put back embryos that are not biopsied for aneuploidy, then overall pregnancy rates are more age dependent, where women under 35, you'll get in that 45% range. Women in their late 30s, it'll drop down to 35 to 40%. And women that are 41 and 42, we're talking about only about a 25% pregnancy rate. Women over 43 in general, pregnancy rates of non-biopsied embryos about 5%. So you can see the decrease of success rate as the age of the woman increases, and that's related to the higher incidence of abnormal embryos that form when you're older. The incidence of aneuploidy at age 42 is about 80%, where the incidence at 35 is 50%, and at 30 is about 30%. So the more good quality embryos we have that are genetically normal, the higher success rates we have. So if you put back a set of embryos or a embryo and it doesn't work on 1 cycle, we don't get too worried, because even in an ideal scenario with a biopsied embryo, the success rate's only going to be in that 50 to 60% range. But if you have 2 cycles where the embryos haven't worked, one has a previous history of recurrent miscarriage or biochemical pregnancies, meaning that the embryo stuck for a little bit and then didn't develop beyond a couple of days past the missed menstrual period, then we're worried is what's going on and do we need to evaluate this further. So the big question when an embryo doesn't stick, the single most important question, and often one that doesn't have a defined answer, is the embryo not developing because there's something wrong with the embryo? Is there something not happening appropriately, or is there something wrong with the uterus, the endometrial cavity that the embryo is placed into? Or even thirdly, does the uterus fine, the embryo fine, but for whatever reason, there's some miscommunication between the two that's not letting embryos stick. So the first question is, do we put back normal embryos? And that's easy to answer. When you look at embryo development, we can look at two different general things. The first is to look at what's called morphokinetic development of the embryo. In other words, what does it look like over a period of days of observation in the lab? And a embryo that is potentially healthy, that's going to continue to develop, will develop into a blastocyst over a 5 or 6 day period. Occasionally we'll see it develop on the 7th day, but a higher percentage of those embryos don't work as well. Embryos on day 5 and 6 are within the sweet spot as far as the time it takes for embryos to develop. And one of the advantages of a blastocyst culture till day 5 or 6 is that if embryos don't develop to that point, they're not good embryos. So it's not worth putting them back. So we now look at embryos that have developed into a normal time frame, and on the 5th and 6th day of development, it looks like a nice normal embryo under the microscope. And that's the first criteria. The second criteria is to see what else can we look at besides, does it look okay under the microscope? What's going on beyond that? And there's a limited amount of stuff that we can learn about embryos at this point. There's a lot of research on this to try and figure out from culture media that something the embryo may release into the media, or some tag or identifier that would say embryo 1 is better than embryo 2. But the reality of it is the only two things we have right now are, does it look like a normal developing embryo at the right time? And the second is, if the patient elects for us to do pre-implantation genetic testing for aneuploidy, does the embryo have the correct number of chromosomes present? And when you biopsy an embryo with PGT, the most common thing we look for is aneuploidy, which is to see, does it have the correct balance of chromosomes present? In patients that have carrying an abnormal disease like cystic fibrosis, where you don't have the disease but you have an abnormal gene for it, in that subgroup, if both the male and female partner were carrying an abnormal gene, you can test an embryo for that specific mutation, and that would be referred to as pre-implantation genetic testing, single gene mutation, whereas genetic testing for aneuploidy is looking at the embryo in a whole to see if the chromosomes are correct. And with 98% accuracy, with 98% accuracy, you can tell if the embryo has an imbalance in the number of chromosomes, is acceptable to put back or not acceptable to transfer. So if we have somebody where we put back normal embryos and we know they're normal because they were biopsied, it's less likely to be the fact that the embryo didn't stick being related to the embryo itself. It's more likely either unexplained or a maternal host issue. Alternatively, if you have somebody that's 41 years old and has done 3 or 4 embryo transfers, and we put back 2 or 3 embryos at a time, we put back a total of 6 or 7 embryos and none of them have stuck, that could very well be just that they're abnormal embryos, and we don't know it unless you do genetic testing of their embryos. There's no way to test after the fact unless the embryo were to stick and then miscarry later on. Most abnormal embryos, if you put them back in, just aren't going to grow, or if they do grow, they grow for a couple of days, you get a negative pregnancy test, and then some of them will continue to grow and then miscarry at 6 or 7 weeks, and in that case you can, when you aspirate the cavity, you can see whether the chromosomes are normal. So knowing whether the embryos were normal genetically is helpful. In general, I like to see at least 2 failed cycles with 2 sets of embryo transfer. 2 embryo transfer procedures were done and an embryo didn't stick. However, in patients that have undergone pre-implantation genetic testing and have failed an embryo transfer cycle, if the couple is very anxious or worried, then certainly we can do some additional testing before putting another embryo back in. We don't do the testing routinely up front because it's not cost effective in any means, and with at least 1, certainly no more than 2 failed cycles, a conversation should take place between you and your doc, whether it's me or one of my partners, on should I do anything at this point or try again without worrying about anything else. Now, with the host factor, if it's not an embryo, let's say, the embryo looks normal genetically, what about the host? Are we putting it into a normal uterus? Because if you take a normal embryo and you put it into an abnormal environment, it might not work as well. Some of those things are done routinely before we've even done an IVF cycle. For instance, the uterine architecture is important in 2 ways. Is the uterus itself normal or abnormal? All of you have had ultrasounds done multiple times. With ultrasounds, particularly with the uterus itself, we're looking to see whether the uterus is a normal size, a normal shape, whether there's fibroids present within the muscle wall of the uterus, whether there's any suggestion of endometriosis in the lining or the myometrial layer called adenomyosis in the uterus. All these things can potentially make it more difficult for an embryo to stick, and most of the obvious concerns are addressed before you've even had your eggs retrieved. The second thing is to make sure the cavity of the uterus is normal, because you can have something hiding in the uterus that you might not see normally. And here again, before we even do a single embryo transfer, you've had some evaluation, and that's done with either, most commonly, a hysteroscopy, where we take a little flexible telescope and insert this into the cervical canal and uterus, and you can actually see in the cavity and tell if the cavity is normal or not. The second approach is to do a hysterosalpingogram, and where a dye is injected through the cervix and a fluoroscopy picture is taken of the uterus and the tubes. And although most people think of that latter test as a tubal dye study or to check if your tubes are open, it also gives us information on the uterine cavity. And the third approach is a saline infusion sonogram, where you inject some liquid into the cavity and do an ultrasound and see if there's any filling defect within that liquid. So all 3 tests are adequate for assessing the endometrial cavity. Our own preference usually is the hysteroscopy, because if there's an abnormality there, we're looking at it and we can tell you what exactly it is. Whereas if you've done a saline infusion or a hysterosalpingogram and there's something in the cavity, we could say, well, it looks like either a polyp or a fibroid or scar tissue or a polyp, or sometimes you can't be as sure. The treatment's the same, you got to get rid of what's there, but hysteroscopy gives us the advantages that we're looking at it, so we know exactly what the abnormality is beyond it just being a space-occupying lesion. So if that's usually done beforehand, it would be rare in our practice to not have that done beforehand in one of those 3 tests. It is possible to develop something that wasn't there when we looked, and that's one of the reasons that we recommend repeating the hysteroscopy if it's been more than a year from the last time you had an evaluation if we're putting embryos in. So, the first thing on the host side, on the women's side, where you're putting the embryos, is the anatomy. Is the uterus normal, abnormal? Is the cavity normal or abnormal? If the cavity is abnormal, then you want to try and repair it if it's repairable. Certain types of abnormalities or variations might not be, such as congenital variations of the uterus. Some things are very fixable: polyps, fibroids, uterine septums, myomas that are in the cavity itself. Those can be easily removed. There's a group of anatomic issues that are less clear, meaning that the cavity of the uterus will be normal, You look in there, it looks like a little funnel the way it's supposed to, and there's no focal lesions. But on ultrasound, you see some fibroids in the uterus. And fibroids can, if they're small and not involving the cavity, usually don't play a role in implantation, although they may grow with the stimulation of the hormones of pregnancy. If they're big, then certainly if they're distorting the cavity, pushing on the cavity of the uterus, or invading the cavity in any way, a so-called submucous myoma, those should be repaired and removed prior to an embryo being put back. If you've got a group of small fibroids, then it gets more into, well, how many is too many, and where they're located, and what's the risk of surgery versus not, and that's a discussion you need to have individually with your physician. In general, my own rule of thumb for intramural fibroids not in the cavity, when they get above 6 centimeters in size, then you need to really consider removing it. Certainly if they're symptomatic in any other way from a gynecology standpoint, they're only going to get worse over time, so you might as well get them out now and maximize your chances of a healthy pregnancy and minimize the risk of embryos not developing. So let's say the uterus is normal. Now what? The next question is, okay, these embryos that didn't stick, were they normal or abnormal? Obviously, if we've done pre-implantation genetic testing, we know whether they were normal because we only put back normal ones. If it's uncertain what they are, then doing some tests for implantation failure makes sense. Genetically, if we put back unbiopsied embryos, then there's a role for doing a karyotype on the male and female partner to see whether there's any rearrangement of chromosomes, a so-called balanced translocation, where you as an individual can have a total number of normal chromosomes, but when you go to transmit them to a sperm or an egg, you get an imbalanced number of chromosomes, and that increases the likelihood of abnormal embryos, and they won't stick. So if we've done PGT for aneuploidy of the embryos, then karyotype's not going to help you because it's already tested the embryos with 98% accuracy. But if we've not done embryo biopsy, then doing karyotypes on both parents makes sense so that we can get some idea of what the risk, if there is any, of creating abnormal embryos over normal embryos. The second thing to look for hidden things such as immunologic factors. We've already tested hormonal things like thyroid and prolactin levels. We've done infectious disease screening for bacteria. So we're looking for the not obvious things. So immunologic factors get into an area of medicine that's kind of controversial. And the test we specifically like to do is called natural killer cell testing. And this is looking for part of the immune system that normally works in your favor. And what I mean by that, there are certain cells, these natural killer cells, that run around your body to look for abnormal cells. And it gets rid of abnormal cells. And as a result of that, it keeps you healthy, gets rid of cells that might be mutating into cancer cells and things. So it's a very good protective part of your body, basically. And the theory is that if this system, this part of the immune system, becomes overly sensitive or overly reactive, it will react to the embryo as being a foreign entity, and hence your body is trying to get rid of it. And that makes sense in that an embryo is not biologically you, it's a combination of you and your partner. So from a stimulation of an immune response, it could set off a response to try and get rid of something that's foreign, and that's the natural killer cells. So you can test for natural killer cells. It's controversial in that some people don't think you should test for them. Other people think it's fine to test for them. You should be aggressive at treating them. And here we test for them. We counsel patients that it's a controversial area of medicine. And if it's elevated, then we're interested in whether that elevation suppresses to a more normal level. So you're not eliminating it. You're not doing anything to affect your ability to get, to counter disease and regular, normal infections, but you're suppressing it to a more normal level where it theoretically won't interfere with the developing embryo. And the most common treatment for that is actually nutritional therapy. It's using what's called intralipids. And if you remember your nutritional groups, if someone can't eat properly, they're given sugar in the form of glucose, they're given protein in the form of amino acids, and they're given fat in the form of intralipids. And if you use intralipids in a very, very dilute amount, very slowly intravenously, you can safely infuse it through a peripheral IV over about an hour. And in patients that are doing IVF that have elevated natural killer cells that have shown in vitro suppression to intralipids, we would recommend using an intralipid injection about 7 to 10 days prior to embryo transfer, and then once a month for the first 3 months of pregnancy. The next area of testing is for what are called antiphospholipid antibodies. The main two are to look at anticardiolipin antibody testing and for what's called lupus anticoagulant, which is not testing for systemic lupus disease, but it's looking for these antiphospholipid membranes, antiphospholipid antibodies that attack all cells in the body potentially. And it doesn't distinguish that this is an embryo versus not. And if it's attacking phospholipid surfaces, which are the surface of all of our cells in our body, then it can be preferentially attacking an embryo. If that's present, usually we consider Lovenox as a treatment. We're not big fans of intravenous gamma globulin because of its side effects and the fact that it's pooled serum. The third area is doing what's called thrombophilic testing beyond the antiphospholipid antibody and lupus anticoagulant. We're looking for just abnormalities in the clotting cascade. And with the patients who have abnormalities in the clotting cascade have microclots in the placental area, and that would predispose to miscarriage, or in this case, failed implantation, which could really be considered a very, very, very early miscarriage because it's occurring before the embryo even gets moving, basically. And that's just a bunch of blood work, and if it's abnormal, then you use a blood thinner to try and help things. So the main issues that we're testing for are to make sure that the cavity is normal, the uterus is normal, that the hormonally thyroid, prolactin hormones are normal, there's no obvious infectious diseases or infections that could cause a problem, and the hidden things that we're looking for are to look for, if you haven't had embryo biopsies, to look for karyotypes to see if there's a predisposition to making abnormal embryos, and then looking for immunologic factors in the form of natural killer cell activity, thrombotic factors to check the clotting cascade to make sure it's not overly active. And then lastly, we get to another potential evaluation, which is called an endometrial receptivity assay. And this is again more in the experimental range. And the feeling, when you're doing an embryo transfer with a frozen embryo, we're usually transferring it on a programmed cycle, meaning that your own cycle has been shut down and we're giving you medication in the form of estrogen and then progesterone to sequence the lining of the uterus so it develops more normally as a natural cycle, so we know when to thaw the embryo. And whereas the length of the first part of the cycle is not as important as long as the lining thickens up to a certain degree. We like to see, a minimum of 6, but ideally more in the 8 to 12 millimeter range. But 7 to 8 is considered minimal normal. And once the lining is thickened up, we add progesterone to the estrogen hormone, and it's actually the number of days of progesterone that converts the lining to be able to implant that embryo. So if we think of this as Velcro, and the progesterone is taking the underlying lining that's there and making it sticky so that the embryo can stick, then it's important that we put the embryo back when that effect takes place. And that little window of opportunity for an embryo to stick is called the window of implantation. And it's usually on the 6th day of progesterone or the 20th day of the cycle and how we program cycles. So most patients will have a certain response to the average dose of medication, resulting in a uterine lining that's appropriate for an embryo to stick in. There are some patients that, despite taking the medications properly, despite the fact that they're on the standard dose of medications, that on a molecular level, their particular individual uterus is not acting like everybody else's. In other words, you're doing everything right, taking the right medications, but the uterus is acting like an outlier. So that we think it's the 20th day of the cycle or the 6th day of progesterone effect, and you've been taking the medication for the proper amount of time, but for whatever reason, the uterine lining itself is not changing on a molecular basis to allow that embryo to stick. The problem is there's no way to answer that by looking at it. We can tell that the lining has thickened up adequately in the middle of the cycle, and there are some patients that, for whatever, either it's just the way they are or because of previous surgery, their linings never thicken up enough to be able to get an embryo to stick. But that we find out by monitoring you during the embryo transfer procedure. And usually we won't transfer embryos if we have a suboptimal lining. We try and do things to make that more optimal as we go. But there are other patients where the lining is beautiful, the hormone levels are great, but they're not getting pregnant. And so, particularly if you've had at least 2 failed cycles, and we usually will put this on the back burner for even 3 cycles or more, there's a test called endometrial receptivity assay to see on a molecular level which genes are turned on and not at the time that an embryo would be transferred. Unfortunately, it requires doing a mock embryo transfer cycle, so we do everything exactly the same as we would do when we transfer an embryo, but we just don't transfer the embryo. So instead of transferring the embryo, we biopsy the lining of the uterus, and we send that biopsy to a laboratory in Spain that will analyze the which genes are turned on at that particular time, and based on an algorithm, they can tell you whether you fall within this window of implantation, or despite doing everything normal, we should move the transfer up by 12 or 24 hours or delay it by 12 or 24 hours. And in patients that have failed 3 cycles of embryo transfer that then have this biopsy done, you will make changes in about 1/3 of those patients that would result in a more positive outcome. The problems are that a lot of these studies are not well controlled. They're not controlled prospectively. Everybody who has a biopsy has a change made rather than going, okay, if I just did 1 more cycle, would some of them get pregnant anyway? So the first problem is the data is still not overly conclusive. The second aspect of it is that it's expensive. It's a couple of $1,000s because we have to do a mock cycle. We have to biopsy it and send this biopsy off for analysis to the special laboratory in Spain. And the third issue is that sometimes, despite making the change, you get the same outcome no matter what. So it becomes important to have that conversation with your doctor, the benefits and the limitations of it. I've had, it's not overly common for me to do these tests in patients for the reasons that we've mentioned. And in the ones that we have, in some cases, a couple of cases, it made a difference. We made a change and they got pregnant. In some cases, we made a change because they recommended a change, but they didn't get pregnant. And in some cases, it said you're doing everything exactly the way you should be, so we didn't have an explanation. So that's available. I would say leave that for at least 3 failed cycles, but it can be done after 2. I would not recommend it as a routine screen, but ERA testing is available. We can do it. It's just again, sometimes it's helpful and sometimes it's not. But certainly if we can't figure out any other explanation of what's going on, then it may give us some added information. Another option is to kind of change the medications around. Different medications work a little differently. In general, the biggest question is not which estrogen we're using for a programmed cycle, but which progesterone. And the question is, do we use intramuscular, or do you use a combination of oral, vaginal, or do you even use a natural cycle to try and transfer the embryos? Statistically, the results are the same with all of them. When you add, you got 100 patients, you do one, 100 patients, you do another, the results are going to be similar in both those groups of patients. But on an individual basis, it works a little differently. Vaginal progesterone is, you have lower blood levels, but more local tissue effects. Intramuscular progesterone, a most common approach, you have predictable blood levels, predictable implantation success rates. And again, one option is just change the equation around and see if we get a different outcome by doing a different progesterone and even a natural cycle as an alternative with some hormonal supplementation. So all those approaches can be used to try and maximize embryos sticking. Sometimes, no matter what we do, we don't get an answer. And then it becomes down to the fact, okay, this isn't working, whether it's because it's totally unexplained or it's something we can't totally fix. A patient is lying that no matter what we do, never gets beyond 5.5 millimeters in thickness instead of up in that 7 to 12 millimeter range. Someone who's had scar tissue in the cavity, and even though we corrected, it's not a normal uterine cavity, or a uterus that's had so many surgeries, it's just not a normal uterus. Somebody with an ongoing medical problem that may or may not be contributing to embryos sticking or not. And in those cases, or even where it's totally unexplained despite everything we do to change things, then one can consider using a surrogacy, basically, a gestational host uterus, to put the embryos into a different person to carry. And that obviously solves all the problems related to the host, but doesn't change the fact that the embryo came from the couple. And, if you have somebody that's 44 years old and doing IVF, where we know the majority, 80% of the embryos are not going to be normal, putting those embryos into a 23-year-old with a normal uterus isn't going to make them work any better if the problem is the age of the eggs and the high incidence of aneuploidy. On the other hand, if you have someone who's 30 and his uterus just isn't doing what it's supposed to do for whatever reason, well, we have totally unexplained implantations. We once had a patient who had multiple sclerosis, actually, and that was the only thing wrong. And she wasn't active at the time, but we put the embryo, had multiple failed cycles. Eventually we used a gestational carrier, got pregnant right away. So again, when all else fails and we have normal embryos to work with, particularly ones that we know are normal, putting those embryos into a gestational carrier is another alternative. So I hope this summarizes things basically. The key here is, particularly when we're transferring one embryo at a time, if it doesn't work the first cycle, that's fine. You try again. If we have recurrent failed cycles, we want to make sure that the things that we don't usually test for are tested for, just to make sure we're not missing something else before you go through 3, 4, and 5 embryo transfer cycles. We try and fix things and optimize things based on what we learned from your previous cycles. And in cases where there's, all else fails, we have normal embryos, but there's nothing is sticking in your uterus, there's always the option of using a gestational carrier. So sometimes we get answers, sometimes we don't. We always have potential solutions, and we look forward to continue to treat you guys and wish you the best. Please discuss things with us as physicians, and We enjoy what we do. We enjoy taking care of you and wish you the best. So stay safe. Have a good Monday afternoon. Take care.